Hi, thank you for the kind introduction and for the opportunity to speak at today's workshop. My name is Sam Takvorian, and I'm a genitourinary medical oncologist and cancer health services researcher at University of Pennsylvania. I will be speaking today about opportunities to use the electronic health record to nudge evidence-based cancer care. The concept of a nudge to improve decision-making is not new, but was popularized in 2009 with the publishing of Richard Thaler and Cass Sunstein's New York Times bestseller, shown at the left. A nudge is defined as a change in the way choices are presented that alters behavior predictably, but without restricting choice. This picture of a decorated subway station illustrates the concept perfectly. Imagine yourself as a commuter who can choose either the stairs or escalator. The choice is yours, but the painting of track lanes clearly encourages use of the stairs. This leverages principles of behavioral economics, which posit that individuals commonly deploy mental heuristics and have cognitive biases that may account for behavior that is non-rational or not consistent with maximizing their individual utility. Nudges take advantage of these heuristics and biases. This nudge might make us more aware of our decision to take the escalator versus stairs, and also highlights the differential health benefits of each choice. Almost a decade ago, Penn Medicine was among the first to establish a health system-based nudge unit, whose charge was to design, implement, and evaluate nudges to promote evidence-based care. It's also important to note that nudges exist on a spectrum, and by design can be more or less directive. Shown here is a conceptual framework depicting a hierarchical nudge ladder. Nudges at the bottom of the ladder focus on education and information framing. Nudges higher on the ladder, such as setting default options, are more likely to influence decision-making, but are also considered to be more paternalistic. Conceptualizing nudges in this way allows one to design and implement nudges whose potency matches the strength of the evidence supporting particular practices. Nudges have been shown to be effective at promoting high-value prescribing in primary care settings. Almost a decade ago, it was recognized that our generic prescription rates were too low, and multiple educational initiatives had failed to move the needle significantly. In November 2014, a change in EHR defaults was implemented across the health system, in which an opt-out checkbox labeled "Dispense as written" was added to the prescription screen. If left unchecked by the prescribing clinician, the generic equivalent medication was prescribed. This change in defaults led to substantial changes in prescribing patterns almost immediately and across drug classes. Note that for most drug classes, rates of generic prescription shot up to 95+%, except for hypothyroid medications, for which generic and brand name medications are not perfect substitutes. This suggests that the nudge did not compromise clinician autonomy and again highlights the important principle that nudges should not restrict choice. Nudges have also been used effectively to promote high-value prescribing in oncology settings. For patients with bony metastases, for example, we face a choice of anti-resorptive bone therapies of similar efficacy and dramatically different cost. We conducted a quasi-experimental study across our health system, examining simultaneous initiatives to promote prescription of the higher value alternative, in this case, zoledronate. Educational efforts and performance feedback were implemented at Site A, depicted in orange. At Site B, depicted in dark blue, an EHR-based strategy of accountable justification was additionally implemented, in which clinicians who ordered the lower value alternative had to justify this decision to pharmacy. Both of these strategies were associated with increases in the rate of zoledronate prescription compared to control, but you'll note that the more potent directive nudge had the largest effect. So I hope with these two examples, which are just a few of many, you've been at least intrigued that EHR-based nudges can be effective at promoting high-value clinician prescribing, both in primary care and oncology settings. But what about patient-facing applications? Increasingly, we've been investigating the use of patient-directed strategies that might complement nudges to clinicians, and I'd like to close with one such example. Serious illness conversations, or SICs, are an evidence-based approach to eliciting patient values, goals, and care preferences. We know from the literature that early SICs improve patient outcomes, such as mood symptoms and quality of life, and are recommended by national guidelines. Unfortunately, most patients with cancer die without a documented SIC, contributing to unwarranted and unwanted aggressive care at the end of life. We have implemented several efforts at our cancer center to support these important conversations, including formal training for all of our oncology clinicians in the evidence-based serious illness care program. Additionally, we demonstrated the effectiveness of a clinician nudge designed to aid clinicians in identifying patients at high risk of predicted 6-month mortality based on a validated machine learning prognostic algorithm. This strategy led to a near 4-fold increase in SIC documentation for high-risk patients, but still there were not SICs for over half of these patients. As a signature project of our NCI-funded Penn Implementation Science Center, we are currently conducting a large pragmatic trial evaluating the use of nudges to clinicians, patients, or both, compared to usual practice to improve SIC rates. This study employs a 2x2 factorial design in which clinicians and patients are separately randomized to receive a nudge or not, leading to 4 independent study arms, as shown. The clinician strategy includes identification of high-risk patients who may benefit most from SICs, as well as clinician-level performance feedback with peer comparisons delivered weekly, shown here. You'll see in this example that the clinician who is receiving this performance report has their performance on SICs compared to other members of their disease team and also to other members of the cancer center. The patient strategy includes a normalizing message and short questionnaire designed to prime patients for these conversations, adapted from a patient-facing advanced care planning tool developed by Ariadne Labs and tested extensively within our patient population. The questionnaire is administered to high-risk patients without previously documented SICs and delivered electronically in advance of an oncology appointment with responses shared with the clinical team in real time via the EHR. The study is about to close, having accrued approximately 4,500 patients over 6 months. We're eager to dive into the data to understand whether this strategy was ultimately effective. But either way, I think this and other pragmatic EHR-based studies illustrates the potential of using the EHR to conduct large pragmatic studies quickly. Our time was short, but I hope these examples were thought-provoking for you in considering the EHR as a tool for the implementation and evaluation of nudges to clinicians and patients alike. Whether intentional or not, the design of the EHR and its patient-facing applications already affects clinician and patient behavior. Thoughtfully altering the way information is framed and choices are presented can predictably change behavior without restricting choice, and thus affords an opportunity to nudge high-value evidence-based care, and most importantly, to improve patient health outcomes. The key, I think, is to rigorously evaluate and learn from these interventions, and the EHR is key to both. I want to thank you again for your time and attention and look forward to discussing your thoughts shortly after this. Thank you again.